Everyone, can you hear me clearly? The back? Yes? No?
No.
Can you hear me? The back? Everyone? All right. See, I've been a lot of things. I've been a surgeon, I've been a teacher, but the only thing that I'm unable to be is I'm unable to be boring. So over the next 30 to 40 minutes, I'm going to take you guys onto a journey onto why we get heartburn or reflux. It's one of the most common problems. How many people here have got heartburn? You can, there you go, there you go, there you go. That's nearly 30%, 40%, and that's the average. Well, the data shows that 30 to 40% of doctors get hamuda or heartburn every time you have a spicy meal, every time you have a little extra to eat, or every time you eat out at the Sheraton or any other conference when you eat a little bit more than you really should be. All right, so it's been a busy day. You know, there's a joke about my patients. I'm a gastroenterologist, so back home in India, since there's a big crowd, you need our nurses tend to strip our patients and get them to wear very thin, just thin gowns. We call them ICU gowns because you can see the patient, you can tell the patient ICU, you know, thin gowns and stripped out. And so there's a joke that a patient came to me with a headache. All right, so as soon as he came into the headache, my nurse said, you know, oh, off with your clothes, lie down. So the guy says, you know, I just came with a headache. No, off with your clothes. Headache, no, off with your clothes. And he's stripped, wearing a thin ICU gown, and lying down and thinking this Dr. Rajkumar is going to come and see me for a headache, and he stripped me completely. And then through, you know, we have a bunch of cubicles, and so through a gap in the cubicles male section, he catches the eye of the guy in the next cubicle. So he sees him, and then he says, hi. He says, you know, this guy is Dr. Rajkumar, just because he's busy, I came with a headache. And the guy stripped me completely. The other guy says, sir, you at least came with a headache. I just came to deliver pizza, and they stripped me completely. So it's okay to laugh, you know. So gastroenterology is a very fascinating field and has given us the opportunity to look into the depths of the human body. And today I'm going to talk to you about reflux. What reflux is all about, why you get reflux, the beauty of the esophagogastric junction. Do you know that the fastest growing cancer in the gastrointestinal tract today is adenocarcinoma of the lower esophagus? It's even faster growing than colorectal cancers. Very, very simple. Lower end esophageal adenocarcinoma is increasing. Why? Because Barrett's esophagus is increasing. What is Barrett's? Constant reflux, acid whacking the wall of the esophagus can create changes in the wall of the esophagus, and those changes are known as Barrett's esophagus. What is the reason for Barrett's esophagus? Constant acid reflux. So there you have a continuum. Reflux, then Barrett's, and then cancer. And this is the fastest growing gastrointestinal tract cancer in the world today. So every one of us at some point of time has reflux. By the way, I must thank Mr. Nijam, Hema and the group at Novo for having brought me here. They said, will you finish in 30-35 minutes? I said, if the minute the audience gets restive, I'll get up and get out, because I feel there's no point in anyone wasting time. You're busy, I'm busy, so I need to make use of every minute. And how long something is doesn't count. You know, Robert Oppenheimer said that in 1/64,000th of a second, an atom bomb goes off, and it can create so much destruction. So it isn't the period of time, but the quality. But please stay focused. All right, so all of us have some reflux at some point of time, and a transient reflux or physiological reflux is acceptable. It's mainly after meals. At least 40% of this crowd will get it after meals today. It does not cause symptoms, short duration. However, reflux becomes significant. I mean, this is some data that we've been doing. It's very important. All of us here, medical fraternity, publish data. Do you know how many patients Parkinson saw when he reported Parkinson's disease? 2 patients. He saw an old man going across the road like this with a festinant gait, and he wrote about it. He saw an old lady with a mask-like faces, and he said these 2 people may be connected. And millions of people today call it Parkinson's disease. He just reported 2 people, one crossing the road and one who came to his clinic. So it's important that we all publish and keep writing papers, medical papers. So this is a paper that we did, morbidly obese type 2 Indian diabetics, in whom bariatric surgery completely reversed their diabetes. Actually, I had originally planned for 2 different talks, so I've just brought in a little. The other talk was fat to fit, and this is heartburn. I felt heartburn is a more burning issue. There are a lot of people talking on bariatric surgery, so I'll just mention a few things now and then. Now, I want you to understand GERD, gastroesophageal reflux disease. Now, everything is important. When you say gastroesophageal, that means acid is coming from below above. Because there are some patients, as you study them, who will have duodenal-gastroesophageal reflux. They will have bile coming into the esophagus, which has a higher predilection for cancer. So, but that's uncommon to have an open pyloric sphincter and an open esophageal sphincter. Esophagus, it's going to the esophagus. It's causing reflux, so reflux. But GER, there's so much of noise. GER is different from GERD. If your patient merely has reflux, it's gastroesophageal reflux. If your patient has disease in the mucosa, even one scratch, then your patient has gastroesophageal reflux disease. So let's get definitions correct and then we can move on. It's frequent episodes, longer duration, occurring during the day and or night, may produce symptoms. And look at the last 2 points. Inflammation / mucosal injury of the esophagus. So you must tell your patient, all of us are going to see reflux patients. Look, you have on your endoscopy evidence of mucosal injury, and therefore you have GERD. Very important slide. Those of you who are sleeping, this might be a good time to wake up and study the slide. Why do people get GERD? As you can see, when you see multiple, oh my God, things like this means it's multifactorial. We know that there are some people whose saliva is so alkaline that it's able to knock off the esophagus, any acid in the esophagus. But those with impaired esophageal, we know that some people, the esophagus doesn't peristalse quickly enough, allowing acid to stay. Therefore, impaired esophageal clearance. So how would you know that? Do motility studies. When you send it to a surgeon or a gastroenterologist and they say, please do motility studies, that means they're suspecting that your patient's esophagus is not clearing out the acid quickly enough. It could be a hiatus hernia. I'm going to pause here. Many people confuse GERD with hiatus hernia. Hiatus hernia is one of the causative factors for a reflux. You can have patient with bad reflux, but his stomach is still in the abdomen. Or you can have a patient whose stomach has gone up into his chest, which means he has a hiatus hernia, but he doesn't have reflux. But if you have a patient with a hiatus hernia plus reflux, then that reflux will not usually be cured unless you pull down the stomach. Do you understand? So hiatus hernia becomes important in a refluxer. You never treat a hiatus. But when you treat a reflux, you have to address the hiatus hernia. And I will show you in the videos that follow how you do that. Acid, pyloric incompetence, delayed gastric emptying. We know that delayed gastric emptying, if you take, for example, a very fatty meal, it will sit for a longer time in the stomach, as we all know too well. You have your biryani, you'll feel like you eat like a python that's eaten a deer, you know. Sits in your stomach, it doesn't empty the stomach, there's traffic jam. It's like the Sharjah to Dubai road. And the hold up happens and the acid pumps up. Finally, it's very interesting. The body to me is fascinating. You know, William Blake, English poet, Nobel laureate, said, you can study all the world in one grain of sand and all of heaven in one wild flower. So you go deeper, you understand so many things. And that's what this is about. There are some people who have bad reflux. When I do a 24-hour PH study, I'll talk about it. but they have no issues because their mucosa is tough like a camel's. So there are multiple factors, and you need to find out which of these factors is operational in your patient. So this is one lady telling a doctor, a guy saying, my favorite, this photo of mine, I had a really tiny waist. And when it's a sonogram when I was inside my mother's belly. Transient lower esophageal sphincter relaxation. Now, I talked about all that. Now, what is the LES? It's fascinating. The lower esophageal sphincter is an area, zone of high pressure in the lower esophagus before it enters the stomach. Now, even Da Vinci, in his dissections, trying to look for a thick muscle there. And every time we remove an esophagus or stomach for cancer, we cut open and see is there something. But there is no thickened muscle. It's just a pressure zone, a high pressure zone. It's known as the lower esophageal sphincter. And we know that decreased lower esophageal sphincter pressure, which guards the esophagus, when it's opened up, acid goes from the stomach to the gullet. Clear, everyone? Got any doubts? Put your hands up and ask me. Decreased LES leg. We know, I will explain to you with a beautiful little physics experiment that was first conceived by Albert Einstein. I think as doctors, we must learn physics, biology, geography, the works, and understand life. I will explain to you why you get reflux if the intra-abdominal length of your esophagus becomes shorter. And that's why when you operate upon such patients, it's important that we increase the length of the esophagus inside the abdomen. Give you a subliminal message. Go back and write. Addison, Graves, Parkinson's. None of these guys were professors. They were just little GPs sitting in Dublin. And today we talk about Graves. We don't talk about even one of the professors at that time. Parkinson. None of them. So no one is beyond noticing something and writing about it. Right, so here we go. These are the various factors. They cause a reflux, and at some point of time, somebody gets a heartburn. Why? So let's look into that. We know, fascinatingly, that each man's esophagus is a genetic imprint, like the retina scan that we do in the immigration when we come into Dubai, like the fingerprint scan. Each man's esophagus is separate. It's unique. God has made us also unique. The intercellular spaces are different for each person. And some of us have greater spaces between the cells, permitting a few H+ or acid ions to go and attack the gullet, and then you get a severe heartburn. Therefore, just because the lady sitting next to you in the conference is having heartburn, it doesn't mean that her acid reflux is more than yours. You may be a silent refluxer, but you may not be having heartburn because your cells are not permeable. Are you with me? However, it does not mean that you won't get cancer. The lady next to you who's having heartburn will take PPI or get a fundoplication and she's all right. You're just walking around because your esophagus is tough. But the acid could cause Barrett's for you, could give you cancer. So we are a very heterogeneous group of patients. This is a drug company telling a thing saying it's only a generic name. There's no real name for it, but it's whiskey. So what is the clinical spectrum? You and I have physiological reflux. Some unlucky people have symptomatic GERD. A little bit more, the esophagus gets attacked and you have esophagitis or pathological inflammation of the esophagus. A little bit more, and you can even land up with cancer and die, or complicated esophagitis. Now, the features of GERD, it's fascinating. It's among, do you know, one of the commonest reasons for so-called chest pain, patients walking into the emergency, into casualty, is GERD. One of the commonest reasons for a change in voice among singers, I've operated on many very, very high-end singers in South India who couldn't reach a high pitch, this aram katta, yaram katta, they'll say, because of this reflux. One of the causes for laryngeal cancer, aerodigestive cancer, is acid coming back and hitting the larynx. Causes for snoring, reflux. Look at this. Children with atypical reflux cough. We just write some cough syrup and send them. But look at the truth that lies beneath. as Shakespeare said. And what lies beneath might be acid coming up, a few drops of acid in a child that are going microaspirated into the bronchus. They set off childhood asthma. I have operated on at least, altogether I've done close to 1,700 fundoplications in India, of which 60 to 70 have been in children, and 20 or 30 have been in children in the ages of 3 to 7, sent to me by pediatricians who picked up very severe childhood reflux and who picked up asthma in these children. So I want you to understand that what you see is heartburn is only the tip of the iceberg. There is a whole spectrum of diseases attributable to abnormal passage of acid upwards from the stomach. And of course, this last bit is the horrible bit: ulceration, hemorrhage, stricture, Barrett's, and adenocarcinoma. It's very interesting. Even cancers have their predilections. It's called the seed-soil theory. Some cancers, like seeds, will grow better in some soils. So you find, for example, that in India we have a lot of, in Pakistan, squamous cell cancer of the esophagus. But what you have in, say, Turkey, Greece, Cyprus, the Mediterranean, China, a lot of these places, and in the West, all across Europe, in the Caucasian group, you get more of adenocarcinoma. Adenocarcinoma is GERD related. Squamous carcinoma is, smoking, BD, that kind of thing related. So that's the difference. Move on from there. So this is something interesting that I wanted to originally talk to you guys about on a new technique of ours that works on reversal of diabetes even in the young patients, but then in not so fat patients. All right, so the three unique, there's a paradigm shift. I want every person here to understand that just because your patient's endoscopy is normal does not mean that he does not have GER. I'm going to introduce another paradigm shift to you guys and talk about something known as endoscopy negative reflux disease or normal endoscopy reflux disease, in which patients have reflux but they don't have esophagitis. So it just means their esophagus is tough. Doesn't mean that they're normal. So please consider the patient's symptoms to be normal. Very often we just brush past the patient's symptoms. One of our earlier prime ministers in India, Morarji Desai, he was asked, are India, is India a forward country or is it a backward country? So he always used to answer in a different way. He said, we're not forward, we're not backward, I think we're awkward. That was typical of Morarji Desai, So like that, sometimes patients can be awkward. Give the patient importance. Of course, you can have the classic erosions. It's very interesting. The guys who go in for ulcers that bleed usually will not come into you with cancer. Beware the patient who quietly comes to you with years and years of reflux, then suddenly he's losing weight, he's become very weak and thin. He is the one who might have developed cancer. Right, now which is the test? One single line for you guys. The test of choice is the ambulatory 24-hour esophageal pH monitoring. Oh my God, this looks like a horrendous, like ambulatory 24-hour nothing. It just means check your patient's acid for 24 hours. Sometimes patients have normal endoscopy. And what does the doctor say? I'm going to treat you for symptom deficit disorder because I can find nothing wrong in you. This is an interesting thing where we looked at all the data comparing obesity and cancer. All right, so what is 24-hour pH? Normally, there is acid in the stomach. Yeah, all of us are agreed on that. So the pH is low in the stomach. pH, as you know, is a negative logarithm. So more the acid, lower the pH, right? All of us are agreed on that. Low pH in the stomach, all agreed on that? Right. Esophagus is normally alkaline. All agreed on that? Yeah. So esophagus pH is normally high. So you have the sentinel, the lower esophageal sphincter, guarding the zone. Esophagus alkaline, stomach acid. Clear? Now, when acid goes upwards from the stomach to the esophagus, the esophageal pH will start falling. Yeah? Because it gets more acidic. Now, everyone whose pH falls just for 1 minute doesn't require a surgery, right? So I need to know how bad my patient's reflux is. And how do I study that? I look at the patient with an electrode, with a pH monitoring in his gullet and the stomach, and study how much acid is popping upwards over a 24-hour period. And there is a very clear thing, I'll show you. So patients with classic symptoms of GERD and normal esophageal mucosa are the non-erosive reflux disease. Now you can see this. Why should I do a pH test? It will tell me, number one, how much acid is going up. Is the patient a nutter or am I the nutter? You know, the patient is right usually. The poor patient is complaining, and just because he has a normal endoscopy doesn't mean that he is normal. I would study my patient's acid exposure. Is the patient having a normal acid exposure or is he having an abnormal acid exposure? Because if the patient has just normal acid like you and I, but he's complaining of symptoms, he could have a hypersensitive esophagus. Don't go and operate on these guys. You'll be doing them a disservice. On the other hand, if the acid exposure is high, then I can help this guy by tightening up his zone. Are we clear on that? So surgeons are everything is black and white for us. Am I going to help this guy or am I not? If I can't help this guy, send him to a medical gastroenterologist. Or if not medical, maybe he has a dental problem. If it's not a dental problem, maybe he has a mental problem. But it's not a surgical problem. So I need to clarify that very clearly. Now, I want to take you through some pictures. What do we look at when we endoscope patients? Can you see this? I want you to... You can see this? I'm going to ask you guys, why does the esophagitis happen in streaks like this in stage 1? Why is it not a big patch of esophagitis? Because normally the esophageal mucosa, God has given us excess esophageal mucosa, right? So it's normally folded. That's why, so that when you eat, it will stretch. But when you endoscope, you blow air and you open out the esophagus. So where the body normally has folds, the folded parts won't be exposed to the acid, only the outer parts. It's interesting to go into everything to understand, and that's why early stage you'll have only this. Later stage starts getting a little bit more, and half his stomach is popping up and down. Can you see that? That means the lower esophageal sphincter area has become so large, allowing the stomach to pop up and down. How is it going to hold back his acid? All clear so far, and this is what we dread to see. That someone who's got a long-standing esophagitis, you look inside and you find he's having a Barrett's esophagus. What is a Barrett's esophagus? Normal esophageal mucosa is squamous. When that becomes columnar, you get a columnar-lined esophagus, which is a Barrett's. And in my mind, it's a worry, because that is a stage that will predispose to a malignancy. And you can see what we say, gastroenterologists, the stomach is putting its tongue out at the esophagus. It's doing at the esophagus. Look at that. That's the stomach down below, esophagus above. Can you see? There's a tongue. It's called gastric tongue of gastric mucosa pointing up towards the esophagus. Then you know that area, if you take a biopsy in that, it's a columnar lined esophagus, and that could give rise to malignancy. Another stricture. Can you see the stricture here? Tight, like a ring. Normally, there's no ring there. This ring has appeared because of fibrosis. Fibrosis because of inflammation. Inflammation because of acid reflux. Clear, guys? We'll go on from there. And then, of course, various biopsies. Now, what is ambulatory pH monitoring? It's no big deal. It's a diagnostic gold standard. The pH monitor placed the lower esophageal sphincter, and you log the patient's symptoms. To me, it's fascinating. Patient will say, sir, at 4:30, after my meal at 2 o'clock, about 2 hours later, I had very severe heartburn. The next day, when you check his 24-hour pH, you will find that the acid has come and washed his lower esophagus at that 4:30 time, and the pH has dropped. When I know that the pH falling is commensurate with my patient's symptoms, then I know that this patient has got severe gastroesophageal reflux disease. Am I clear?